Everyone, I hope you had a good and healthy lunch. Hope it was satisfying and tasty. We'll have some more snacks in the afternoon, a little bit later on. So our next speaker is Dr. Christopher Teshima. Dr. Christopher Teshima is a gastroenterologist at St. Michael's Hospital. He's the co-director of the Advanced Endoscopy Fellowship Training Program and an assistant professor at the University of Toronto. His focus is on therapeutic endoscopy procedures, including early gastric cancer. He completed his residency training at the University of Toronto and Alberta and an advanced endoscopy fellowship at Erasmus University. Dr. Christopher Teshima.
When I was at Dr. Coburn's gastric cancer symposium last June, I didn't know about this organization or this meeting. And, I had a very fortunate to sit beside Kate, and we learned all about what you guys do. And I think patient advocacy is an extremely important component of advocating and promoting and advancing care in this disease, and in this disease in particular, but many different diseases. So I'm going to talk from a gastroenterologist's view, what we can do and what's our role in people with stomach cancer. So my introductions have already been given, and as mentioned, I work at St. Michael's Hospital here in Toronto, where we do a lot of considered advanced endoscopy procedures and see patients with early gastric cancer. I have a family. I'm 8 years into my practice. But learning never stops, and I have a particular interest in this disease. And so I actually spent 2 months earlier this year in Tokyo at two really advanced centers that focus in stomach cancer, where in a given day, 8 to 10 patients were having early gastric cancer removed by endoscopic resection. So I do have a passion about this, and I'm hoping that we can help advance the minimally invasive endoscopic treatment and detection of stomach cancer in Canada. So many of you probably haven't seen endoscopy before, or at least from the inside. I've been promised that everything will work if I submitted my... Is there a way to click on this? So I need to click on the slide. It's okay. I'll keep going, but I will need to get this figured out shortly. I really wanted to use my own laptop. In any event, many of you may have had endoscopy before, or your loved ones who have had stomach cancer obviously had endoscopy, and that was how it was diagnosed. But this is an example of a stomach cancer, and I was going to show you how that compares to a normal stomach. One question that comes up commonly is, why can't we screen for this? We screen for colon cancer. Why can't we screen for stomach cancer? And while this is done in Asia, because it's a very common cancer, a very common disease, there was a long time period where stomach cancer was the #1 cause of death in Japan, of any cause. But that's not currently what's recommended in the West, and the simple reason is it just doesn't kind of pass the bar when you look at a cost-benefit analysis, that the frequency in which we see this illness in the West is not sufficient to justify the expense from a healthcare payer perspective. And so it's estimated that it would cost about $250,000 American to prevent one stomach cancer by screening, which doesn't typically meet the bar. And even in these countries where screening is conducted, most cases are still detected not through the screening program, but through symptom evaluation. I unfortunately missed, I think her name's Leanne, the nurse from Northwest Territories, her presentation, and she asked the question, the struggle of getting seen and having to push for investigations. This is a big challenge, I think, in Canada. And I think a big difference in Asian countries is there is substantially more awareness about stomach cancer or other GI cancers. This is a well-known thing. Everyone knows someone who's affected. There's a national screening program, so it's in the mind frame of people. And so when you have these symptoms that are not clear-cut, people push for investigation. And while people in this room are very motivated and have, because of what's happened to you, I think the average person out there in Canada isn't, and is probably all too willing to be told, by their GP, everything is fine, nothing needs to be done. And so it's a rare exception like Leanne who pushes. And I think that's part of the problem. So for the main type of stomach cancer, intestinal type, there's a series of changes that happen. You don't need to know this, but basically it starts with infection with this chronic bacterial infection, Helicobacter pylori, and there's a series of changes that happen to the stomach over time. And along that pathway, there are many different points where intervention can take place to change a person's risk and abrogate that pathway that leading eventually to cancer. And so it begins with infection with this bacteria. Now, the problem is that most often people get infected as a child, and then that bacteria just lies there dormant and doesn't really cause, for most people, many symptoms, and then can rear its ugly head many decades down the road. Certainly in high-risk populations, there's been some efforts to look for and detect Helicobacter. I didn't hear where Leanne was from in Northwest Territories, but when I worked at University of Alberta, there was an effort to go to the far remote north of the Northwest Territories, where gastric cancer is extremely prevalent. And we were doing a pilot project of flying into communities and doing transnasal endoscopy unsedated and doing, a few hundred patients a day and looking to see who has Helicobacter. Because if we can find it, then we can eradicate it and we can prevent, hopefully, that person from getting cancer. But another problem is that I think a lot of endoscopy that's done in our country, in our continent, is done poorly, and that many of my colleagues would not have been able to differentiate the differences between the left and right side of the screen. And so when I see a patient, actually it's my practice, when my residents, is I biopsy every stomach. I'm always looking for Helicobacter pylori, even when I think it's negative, because I think it's a really easy opportunity to identify a risk factor that can be changed. Now, the vast majority of people who get Helicobacter, though, would not be at risk, and it's a subset who have a certain immune response, who then develop this change of this chronic inflammation that leads to cellular change, which we call intestinal metaplasia. And that can be seen. Okay, so it can be seen, again, if you know what you're looking for. And all too often, we get referrals now for patients where nothing was seen. Their stomach is completely normal. They were having endoscopy. Mainly, it's usually they were going to do a screening colonoscopy, and for some reason, they decided to do upper endoscopy at the same time. Everything looked normal, but we took these biopsies, and we found this intestinal metaplasia, and what am I supposed to do with it? I tell you this because this, I think, also speaks to the fact of what this organization can help push for and what people like me have to help push for, which is further education and training of the doctors who do endoscopy, because this stuff can be seen if you know what to look for, and these are just some examples, but often isn't. And even if you don't know what to look for, what I teach my trainees is that there is a process by which we can sample the stomach so that even if you're not good enough to see what you should be seeing, you can still take biopsies in a specific protocol that in the vast majority of patients will identify who has this intestinal metaplasia. So if you follow this kind of mapping strategy, we can identify who has this change that's closer to the progression towards cancer. But then what happens when we find it? In the United States, they would say, well, who cares? They actually don't tell people to do anything with this information unless you've had a family history of stomach cancer, or if you happen to be of a certain ethnic group where we think you're high risk. So if you're a Caucasian and you don't have a family history and your doctor does these biopsies, they may tell you everything's fine and that you don't need any follow-up. And a recent survey in the US of gastroenterologists, 80% said that they wouldn't follow up on this and said they didn't think there was any particular guidelines to do so, which is false compared to what's done in the rest of the world. So in Europe, we would say, well, this is a precancerous change. It's a low-risk precancerous change. Only 0.25% of people with this would get cancer in a given year. But it is something that's identifiable that can be acted upon. In Asia, they would look much more closely. So what do we do at St. Mike's is when we see these patients, regardless of your family history, we say, we want you to come back every 3 years. And we want to look in a very detailed way because I think that with a well-trained eye, I can see the changes, the visible changes where early cancer is starting. But if you're not looking, you can't find it. And then even when it is there, I think all too often it's not seen. And so the last kind of place where endoscopy can help prevent cancer or early treatment of cancer is to detect these early changes in the stomach that may reflect a stomach cancer. And what we see, at St. Michael's, we're a big Barrett's esophagus cancer center, which is pre-cancerous changes of the esophagus. But it's not an uncommon thing where a patient is sent to us for something, and in that process of us looking, we find an early stomach cancer. So there are many different forms that early stomach cancers can take, and some of them, where they're a visible protruded lesion, I think any endoscopist would see. But some of the challenges is you can have a loved one have an endoscopy, and they may see this thing, but a flat little red patch may go unrecognized, and the significance of it may be missed. And so this speaks that the big difference between the West and the East is that in the East, this is something they see very often, and they're all trained very well to do. And in Canada, I think most people going through training programs would very rarely see these kind of patients or these kind of lesions and not know what they're looking for. I know this isn't very encouraging information that I'm telling you, but this is part of the problem of how challenging it is for this condition. And fortunately, technology is helping, and technology is advancing, and I think this is going to become better. So, on the left, I would say that endoscopic image is normal. There's a new scope that's come out in the last year which has these different imaging properties, and it's really allowing us to see things that aren't easily visible before. And so when I'm looking with standard endoscopy, things may look to be normal, but if you're using the new technology, things start to stand out. And so this is something called link color imaging, and there's blue light imaging, and something that looked normal in the stomach can now be that there's a visible lesion. And I don't know if you can see that, but right here there's a cancer. But this challenge here is this is still relying on individual human detection and skill. I was at this conference 3 weeks ago, and I think 5 years from now this is going to be a very different story and much more encouraging. I think artificial intelligence will really be coming to change the way that endoscopy is done. And already with deep machine learning, computers can be trained to effectively diagnose and detect where in the esophagus a precancerous lesion is. So if we can train people how to thoroughly look at the stomach, I think the computer can flag to them where in the stomach there's a possibility that there's something wrong. And we'll tell the doctor, this is where you need to take a biopsy. And then, they may not see it, but if they get the biopsy that shows there's a precancerous growth, then that person could be sent to a place that can do something about it. So I think there is hope as technology advances to help our lack of ability in the West to detect these things. It still doesn't address the problem of access, of getting, having the patients with these vague symptoms undergoing endoscopy. But once they do, I think even now things are being missed, and technology will help overcome that. So what happens when we find early gastric cancer or any gastric cancer? So this is a cancer here, and this is one here. They don't all need to see Dr. Swallow. I mean, if you have to have surgery, that's where I would want to go to. And surgery remains by far the main this is the standard of care for gastric cancer. It's surgery until proven otherwise, but there are certain patients and cancers who can be effectively treated without having to lose part of their stomach through endoscopic resection. And so this has been done for quite a long time in Asia, and quite clearly small tumors that don't have high-risk features can be cured through endoscopic resection. And increasingly in the East, they're expanding this to include any size tumor so long as it's very early and doesn't have high-risk features. And so I want to just describe one patient who I recently saw who I was hoping could come today, but she decided to go back to Hong Kong for the winter. But she had come into hospital a year ago, I was not involved in her care, and she had a gastrointestinal bleed. So she had been bleeding from something in her stomach, and they did a scope, and she had a polyp in the antrum. So the antrum is the lowest portion of the stomach. So they said that, okay, you're bleeding from this polyp, so they cut it out, and they said, oh, this is high-grade dysplasia, so this is almost cancer. We better watch you pretty closely. And so in the course of the next 10 months, she underwent 5 endoscopies. at an academic teaching hospital. And through that time, they could see that this polyp had come back, but the biopsies consistently showed only inflammation, no signs of cancer. But they were, this is worrisome. Why is this polyp coming back? Do we have to worry about it? Hey, Chris, can you do an ultrasound inside the stomach to look inside this lesion? So I looked at the antrum at this polyp, and I thought there's nothing worrisome about this polyp. However, in the uppermost portion of the stomach, nowhere near the antrum, and this, I don't know if you guys can get this video to play. This person who had undergone 5 endoscopies had a lesion. And it's shocking that this could have been missed. And clearly that there's been growth over the year, but this woman had a stomach cancer that was right below the way the esophagus and the stomach join together. So this is the top of the stomach, and this is right the junction of the stomach, and there's this kind of flat tumor that extends down, and this part that sticks up like this. Now, it looks bloody because we had gone in and out and traumatized it, but it wasn't like this initially when I came in. And the challenge for this patient is because this tumor comes right up to the top of the stomach. This is the scope looking backwards here. And there's the bulky part of the tumor here, but it extended to within a centimeter of what we call the gastroesophageal junction, where the stomach and the esophagus connect. And unfortunately, it's very difficult to do an anastomosis to rejoin you, and you can't really just cut out that portion of the stomach. So basically, the consensus was, you have to have your stomach removed. Sorry, I'm going to go back and forth one more time. We didn't want to do that.
Sorry.
It's okay. So, the staging investigations were done. There's no sign of any spread. There's no lymph nodes that are seen in imaging. And the consensus, though, from multidisciplinary tumor board is, you have a cancer and you have to have your stomach removed. And the surgery that you need to have is total gastrectomy. But the patient didn't want to lose her stomach, and she was being very stubborn about this. She actually was booked for OR, and a few days before, she decided to cancel, and she couldn't do this. And, having come from Hong Kong, in the country of origin, she knew of people who had stomach cancer who had had their cancers resected by endoscopic resection. And so the question was, can we do that? I don't know. And so not to show it too much, but just a few highlights of what this looks like. Basically, for early cancers, we can cut them out from the inside by separating it from the underlying surface. So the tumor is on the top. This kind of bluish whitish stuff is the top of the muscle and the tissue between the muscle. And with a variety of devices, if your tumor is early, we cut it out. And we cut it out without you having to compromise the integrity of the stomach. The main disadvantage of this is that we don't get to sample the lymph nodes. And lymph nodes metastasis is a huge factor in terms of your survival. So, but we know from the data from Japan over tens of thousands of patients from surgical series, the likelihood of lymph node spread based upon stages of cancer. So if your cancer has really good pathologic staging, we can take it out this way and have fairly negligible risk of lymph node spread. And so this is the defect. This is the top. This is the junction of the stomach to the esophagus, and this comes within maybe a few millimeters. And here's the defect of where the tumor was. So for the patient, here's the junction of the esophagus. So this could not have been done from surgical means, but for her was a curative resection. So how do I go back? I got it. So it's an option, and this is kind of the standard of care in Asia. And in fact, over half of patients who get diagnosed with stomach cancer in Japan will have endoscopic resection, mainly because they're lucky enough to, maybe lucky, or I don't know how you want to describe it, but that they are diagnosed so early. And with that are able to achieve high rates of success for both the standard 2 centimeters or smaller. This one was a 3 centimeter tumor, so it's kind of beyond that. But with negative margins, no evidence of any pathological features of concern. And in fact, in Japan, when you compare what happens for these early stage cancers in patients who have ESD is the endoscopic resection, and gastrectomy, of course, is removing the stomach, the R0 resection is how likely you are to get the whole thing out completely in one piece with negative margins. And it's pretty good. And doing this first doesn't prevent the patient from subsequently going on to surgery. So I can do this, and if I don't get a curative resection, that patient could still have the operation. And at least the data from the East suggests that doesn't compromise the effectiveness and the quality of the surgery that comes. So, and the morbidity, this patient was in hospital for 2 days. I monitored her only for bleeding risks, which didn't happen. And then she went back home and she resumed her life. So if you're lucky enough, and again, I say that in quotation marks, but if you're gonna have stomach cancer and you find it early, this is something that is an option, but one that I think even in my own institution, where we do this all the time, is not necessarily something that even our surgeons are aware of, or sometimes the oncologists are aware of. So it's part of my job to promote awareness of both quality of diagnostic endoscopy so that we are detecting the precancerous lesions more effectively, sooner, and more consistently, and that when something is found, that we're able to treat it in the most minimally invasive way. And by all means, there are many times where now, because I am promoting this message around the province, patients are sent to me and I say, no, I look at it and this patient needs gastrectomy, this patient needs gastrectomy, and that remains the standard of care. So this only reflects an option for a real minority of patients in Canada, but it's something that could be considered for some. Thank you very much. Doing questions?
No. Oh, okay.
I got a voice. Endoscopic resection is a less invasive way. You don't have to open the person up. You can just do it through the throat and do the entire procedure.
Yeah, sorry, I should have explained that. I make these assumptions, and so it basically is the same as when you're having a diagnostic endoscopy. Obviously there's differences. We do this under general anesthesia because it can take some time. So right, there's no incision in the outside. We go down through the mouth and the throat into the stomach and use a variety of tools and knives to basically cut the tumor out from the inside. And there had, for the longest time, been a lot of concern, like, oh, what if you make a hole in the stomach, and is that going to be emergency surgery? But again, the technology advances, and I make holes in the bowel and the stomach all the time, but we're able to effectively close those, and our patients have done very well. So it is minimally invasive, speedy recovery, short stay in hospital, no real level of functioning compromise, but only for that early patient who's found, at the right time. Yes.
Me?
When you're cutting out,
Oh, I'm sorry.
go ahead. When you're cutting out the cancer and you're tampering with those cells, could it spread by cutting
Can it
into
spread?
into the cancer and cells escaping? Or I'm not really familiar, but I've heard things like that. I've just heard like if you tamper with cells, I don't know if this is true. With cancer cells, you can spread.
So yeah, that's a very good question, and one I think with good theoretical concern. Like, could this be more dangerous? So the real, the question is, because I'm cutting out within the lining of the stomach, and the cautery, we use heat, thermal energy and heat to help cut and seal these blood vessels. Those are killing those cells. And there hasn't ever been suggestion that this would lead to spread down the stomach, that you'd be breaking a cell off that would fall off and die effectively from its origin in the top of the stomach and fall to the lower portion of the stomach. I think there would be a theoretical concern if I wasn't cautious in what I undertook, and if there was a tumor that was deeply through the wall of the muscle of the stomach, and I cut through the middle of the tumor and ripped open the stomach and had a leak outside the stomach. So I think that would be a concern where there could be, intraperitoneal dissemination. Intraperitoneal, sorry. And they could spill outside the stomach if I've compromised the integrity of the wall of the stomach. But for the most part, really the issue is whether or not there's cancer cells that lie beneath where I've cut. And if the piece that's taken out doesn't show a clear margin all the way around where there's cancer-free normal tissue and all the cancer is contained inside, then I say that's inadequate and you have to go to surgery. Or even when we get it all out, but there's something in the pathology that says, hey, there's some cancer cells that are hanging out really close to some blood vessels or really close to these lymphatic veins. So even though we don't see any spread, I'm worried that even though we don't see any lymph nodes, maybe there could be. So then you should still have surgery. So we really are saying there has to be a perfect outcome, and if there is anything less than perfect, then you still have to have surgery. And that surgery takes care of the possibility that there's cells that are still there.
Hello.
Hi.
I'm very interested to meet you.
Okay.
16 years stomach cancer survivor.
Congratulations.
Thank you. Now, the surgeon who did my surgery was in British Columbia at the Langley Hospital. His name was Dr. Ross. He'd only been a surgeon about 5 years. And they originally were going in to take the upper part of the stomach, which had the ulcer and had signet ring. But when he opened me up, it was less than a week. It had already gone through, and 9 out of 12 lymph nodes were affected. At that split decision he made was to make a pouch, and I was his first pouch. And my question to you is, I mentor people all over the world since my gift of a second chance at life. Nobody that I've met, other than this one fellow in Florida who's longer survivor than me with a pouch, he will be in my presentation later, has heard of the pouch. And look at me. The ones that I am mentoring are exactly what you're talking about, the esophagus and all that, and they're dying. And I'm getting a lot of them that I'm mentoring that read my amazing story online, that big question. So I've already had my stomach out. Can I not get the pouch in? And hey guys, I'm not a doctor. You got to go back to your doctor and talk to them. So this is new and it's upcoming, and it's a number one big question is why are the surgeons not discussing this option with them? Sorry.
So, no. First of all, I'm very, very thrilled to see how well you are. And that's a tremendous story. And I think it's wonderful that you are trying to bring more understanding and knowledge, education about what's happened to you and your disease. Signet ring is a different story. And I was talking, about intestinal type cancer. And just to start with, I would never touch a signet ring cell tumor from an endoscopic resection, and that person would need to go to surgery or other, more invasive surgeries or chemo. So limited kind of focal resection of a signet ring cell would not be something that we would be considering. I think in terms of, I have to admit my ignorance. I don't know really what you're talking about, which either means what you experience is very unique, or I'm just uneducated, I guess. And maybe that's reflective of the problem. But I'm also the wrong person, and because I'm not a surgeon. And so perhaps Dr. Swallow can address that question next. Okay. Okay, thank you. Thanks, guys.
Thank you so much, Dr. Teshima. I think I appreciate your honesty about potentially being ignorant to some of the experiences that patients might have. I think that this is the reason exactly why we run these conferences, is because we're learning from each other and we're learning from each other's experience. So the next person I'd like to introduce, and every time I introduce her, she gets a little flustered because I call her my hero. And look at her over there, she's already flustered. But she, back in 2011, she was my surgical oncologist. And honest to God, I just owe my life to her, because had she not performed a very long and intensive 8 to 10 hour surgery on me, I would not be standing here and talking in front of all you fine people.